Yeah, so this afternoon I'd like to share some of the early data that have come out of the SA Athlete Heart Study. And as you'll see, we've done quite a bit. We've assessed these endurance athletes in detail with multiple modalities. But today I'm going to mainly share the MRI data because I think they're relevant and they're new, they're novel, and they made us think and made us hungry for more of this.
I think yeah, there we go.
Yeah, it's working. So, of course, we all know that regular exercise is effective in preventing and treating many chronic, non-communicable lifestyle diseases. Exercise improves cardiovascular health and longevity. We know that Olympic athletes live 6 to 8 years longer than the average population. So there's something good in exercise. But the Copenhagen City Heart Study made us think, because the study suggested, and this study was published quite a few years ago already, that moderate exercise is beneficial from a cardiovascular point of view, but also from other non-communicable diseases point of view. So there's less cancer, diabetes, hypertension, there's less stroke, even less Alzheimer's, neurodegenerative diseases. But those who exercise more than 4 hours per week at a fast pace, and at least 3 times a week, appeared to lose all those benefits. And the curve that was plotted eventually looked more like a J-shaped curve, and there may be some harm in pushing ourselves too hard physically. And this is what Dr. Schnoll published years ago in the Journal of the American College of Cardiology. So sedentary joggers, light joggers, moderate joggers benefit from all-cause. There's less all-cause mortality. There's also less cardiovascular mortality, but strenuous joggers seem to lose the benefit and put themselves at risk. Of course, there's many criticisms, and we know that that group of strenuous joggers was only a small group. Is that infamous J-shaped curve? So is it so that strenuous exercise over time, pushing ourselves too hard, puts our body at risk? We know from research over the last 10, 15 years that long-term excessive endurance exercise causes pathological and structural remodeling of the heart. Chronic training for and competing in extreme endurance events, like comrades, for example, of the UTCT mountain trail run, may cause acute volume overload of the atria, both atria, and particularly the right ventricle, with transient reductions in pump function of the right heart and elevated cardiac markers. And most of these changes return to normal within about a week of rest. The strenuous exercise may lead to areas of myocardial fibrosis in the atria and the interventricular septum in the right ventricle, with an increased risk of arrhythmias. And we know that age, body mass, baseline troponin, exercise intensity, and change in body mass or weight loss during exercise are independently associated with elevated increase of cardiac markers after exercise. And these markers, troponins, have a prognostic implication as well, with an increase in future mortality and cardiovascular events. And marathon runners who had elevated post-exercise elevated levels of troponin, and who were assessed with cardiac MRI, were demonstrated to suffer changes, areas of acute necrosis, and areas that may well signify fibrosis of previous exercise. Premature ventricular beats or contractions and ventricular arrhythmias during exercise often originate from, which originate from the left ventricle and the left ventricular free wall or the right ventricular free wall, carry an adverse long-term prognosis. The majority of those patients have abnormal MRI studies with late gadolinium enhancement. I'll show you some images later on, which represent focal scar or focal necrosis. And those areas and the quantification, the quantity, the amount of scar is an independent predictor of major adverse cardiac outcome. And the presence of myocardial fibrosis assessed and quantified with cardiac MRI was observed in 12 to 50% of endurance athletes. And it was associated with longer endurance exercise participation, higher years of training, exercise-induced hypertension, and this was demonstrated in a group of triathletes, supporting a link between lifelong endurance exercise and strenuous exercise and myocardial fibrosis, and with that, adverse outcome. Fibrosis was frequently demonstrated. Recent studies, particularly European studies, found that the hinge point between the right ventricle and the left ventricle, the so-called right ventricular insertion point, often demonstrated enhancement. And that's what we rarely see in ischemic patients, in patients suffering from coronary artery disease. We do see it in patients with cardiomyopathies, hypertrophic and dilated cardiomyopathies. And the cause, the etiology, and the significance is still uncertain. But the enhancement at the hinge point in athletes suggests us a non-ischemic etiology for fibrosis. And it reflects possibly an increase in mechanical stress, the acute right ventricular volume overload of the right ventricle with endurance exercise. Careful inspection of the distribution of late gadolinium enhancement and fibrosis in certain studies have also revealed subendocardial and epicardial enhancement. And that could be suggestive of previous myocardial infarctions, if you think about the subendocardial locations, or myocarditis, if we consider the epicardial location of fibrosis. Just to demonstrate what a late gadolinium enhanced MRI study in an endurance athlete may look like, you see the rounded left ventricle and the right ventricle, which wraps itself around the left ventricle, with enhancement, mid-myocardial enhancement in the septum, the basal septum, and hinge point here. So the hinge point between the right and left ventricle enhanced. Further, we see the spotty pattern here, which may be suggestive of previous myocarditis. Another example of hinge point enhancement, and this was demonstrated in 35% of males and 40% of females endurance athletes. Very little attention has been given to atria, and we know that the atria can cause problems in the long run in endurance athletes. There's a far higher risk of atrial fibrillation, atrial flutter in endurance athletes, an estimated 5 to 10-fold increase of atrial arrhythmias compared to the general population. And a colleague of ours in Melbourne, André Lagerge, a sports cardiologist, described eloquently the so-called dam wall effect with exercise. And the idea is that as your heart rate increases and the mitral valve closes more frequently, pressure in the left atrium increases, eventually resulting in dilation of that left ventricle, stress, strain, and perhaps fibrosis. So far, only one group, and the group in Utah, looked at myocardial fibrosis or late enhancement in atria, and it's a group of Professor Marouche, who have a long-standing program studying patients with atrial fibrillation, and they developed a protocol, an MRI protocol, which allowed them to quantify and regionalize left atrial enhancement. And so far, they're the only group who've published any data on the presence and significance of atrial scarring in endurance athletes. So they studied 20 endurance athletes and compared them with healthy controls. And of course, they found that the atria in endurance athletes are larger than those of the health of the non-athletic control group. They also described marked presence of atrial fibrosis in the endurance group, with 15.5% plus minus 6% in the athletic cohort compared to less than 10% in the control group. Scarring in a control group is not expected, is not to be expected at all, and there's been some comment about the protocol that they used, which differs from the protocol that we've used in our study and the protocol that was developed in Amsterdam. So we decided to study our local athletic population. South Africa is renowned for endurance athletes, and we have so many races, and I encounter endurance athletes on a weekly basis, often with symptoms, palpitations, or fatigue and shortness of breath. And we decided to take it further in endurance and come up with a study that would look at our local endurance at the local athletic cohort. The title of our study is The Prevalence of Focal and Interstitial Atrial and Myocardial Scar in South African Endurance Athletes as determined by contrast-enhanced cardiovascular magnetic resonance. This is a preliminary study, it's a pilot project, and it looked at, because we've recently finished our project, the intake of our first 40 athletes, and we assessed the morphological and functional cardiac characteristics of a group of endurance athletes who had been exposed to high endurance exercise loads for at least 2 decades. So all our athletes are middle-aged. The objectives were to determine whether the cohort demonstrates signs of atrial myocardial fibrosis and other characteristics which may explain the increased risk of atrial fibrillation, atrial flutter, and cardiovascular mortality in this group. And we specifically focused on the prevalence of focal atrial and ventricular myocardial fibrosis using the late enhanced cardiac MRI. I've been studying patients with cardiac sarcoid in the past, and we started in the mid-90s, and we've got extensive experience with the use of the late enhanced cardiac magnetic resonance, and it's changed the face of medicine completely. Ischemic and non-ischemic cardiomyopathies has become a diagnostic tool. Non-invasive, high resolution, gives us functional structural information, prognostic information, and it helps us manage our patients. And we decided to look to determine whether there's a correlation between the presence of myocardial fibrosis, i.e. the delayed enhancement, and premature ventricular beats during or early after exercise testing, as the group of Zorzi in Rome found a correlation between the presence of ventricular arrhythmias and myocardial fibrosis, and they actually pinpointed, they used the late enhanced studies to determine the focus of the ventricular arrhythmias. We also wanted to use the late enhanced cardiac MRI to localize and quantify left and right atrial fibrosis, and to determine whether there's a relationship, of course, between total training volume, the years of training, the weekly training hours, the intensity of training, and the atrial volumes, and the left atrial booster pump, conduit functions, and the presence or the absence of fibrosis in the atria. The idea was to include endurance athletes between the ages of 40 and 60, males as well as females, who had been participating in sustained high volume exercise, high intensity exercise habitually for at least 2 decades, and then at least 4.5 hours per week of exercise with at least 3 or more sessions per week. Exclusion criteria were, of course, those with known underlying cardiac disease, cardiac arrhythmias, conduction disease, cardiomyopathies, valvular heart disease, coronary artery disease, any other structural form of cardiac disease, which of course would have been picked up with our assessment and would have muddled the waters, and we wouldn't have known if this was related to exertion in the first place. Another common contraindications for cardiac MRI, such as advanced renal impairment, which would preclude the administration of gadolinium or metallic implants, devices, clips, or claustrophobia, and of course allergy for the contrast agents would have prevented them from taking part in our project. All individuals who enrolled in our study provided us with written consent. All our athletes, after providing us with consent, were physically assessed, had resting ECGs, exercise ECGs, either by cycling or on the treadmill. All had advanced cardiac ultrasound. I'll show you some examples now. And eventually all had the late enhanced cardiac MRI studies. As an example, the overwhelming majority of our endurance athletes, of course, had incomplete right bundle branch block conduction, as it's well known that endurance exercise dilates the right ventricle over time, stretches the conduction system in that right bundle, which is quite fragile, is the first to delay in conduction. After resting ECG and exercise testing, all of our athletes were studied with sophisticated cardiac ultrasound. It's semi-automated, so it allows us to very quickly, in just a few heartbeats, three-dimensionally assess the heart, in this case, left ventricle and atria, but also right ventricle and right atrium. And it allows us to determine not just the volumes, but also and pump function, but also strain. We use three-dimensional right ventricular acquisitions to study the right ventricular function, and three-dimensional cardiac ultrasound is nearly as accurate as cardiac MRI, but far less costly. We also assessed our athletes with the strain analysis of the ventricles, both ventricles and both atria. And strain is far more sensitive in determining early myocardial changes and myocardial dysfunction and fibrosis and atrial fibrosis than just quantifying volumes and ejection fractions. This is an example of the semi-automated quantification of left atrial strain. This can all be done in one simple breath hold. Eventually, all of our athletes were assessed with cardiac MRI. COVID made things a little bit more difficult, so we had to discontinue our study for a while, but eventually all our athletes or nearly all our athletes were studied with MRI. And our colleagues at Constantiaberg Medical Clinic were very, very supportive and prepared to study our athletes after hours, basically Saturdays. And they were all studied with a 1.5 Tesla magnet, using CNE imaging to determine volumes and pump functions of the atria and the ventricles, with an in-plane resolution of 1.3 by 1.3 square millimeters. And all also had three-dimensional delayed-enhanced contrast-enhanced images of the atria and ventricles with a voxel size of 1.25 by 1.25 by 2.5 millimeters. And they were reconstructed to smaller voxels because, of course, the criticisms that has been there for such a long time is that the atria are so thin-walled that with older technology, it was basically impossible with MRI technology to reliably study the atrial walls and reliably determine the presence or absence and amount of fibrosis or delayed enhancement. The delayed enhanced study took about 15 minutes, but all in all, patients spent often over an hour in the tunnel, and I think Jeroen can speak for himself. He was our first guinea pig, basically, to check if we could get this to work. So often patients had to spend up to 60 minutes in the scanner to have full cardiac assessment. And with MRI, we looked at the left atrial volumes and the global functions. We looked at strain assessment. And strain was determined by two orthogonal views, angles, 4-chamber and 2-chamber. And this is what the plotted curves would look like, the strain imaging, strain quantification of the left atria with the reservoir phase, the conduit, and the atrial booster pump. So MRI allowed us to quantify and analyze left atrial fibrosis, as well as myocardial fibrosis, left and right ventricular fibrosis. Apart from quantifying the amount of scarring, we also regionalized the presence of scarring in the left atria. It's new, and there's some data that suggests that there may be predilection of scarring of the left atria. An example of a reconstructed left atrium of an athlete without any atrial scarring, atrial fibrosis, and an example of an individual with 18% left atrial fibrosis. See the mitral plane here in the pulmonary veins entering at the back with the left atrial appendage over there. There's an interplay between strain and fibrosis, and it's been demonstrated before in populations with atrial fibrillation or paroxysmal atrial fibrillation. Atrial strain is impaired when fibrosis is present. This is an example of impaired reservoir strain, conduit strain, and contractile strain in individuals with left atrial scarring. Our findings, of course, were statistically assessed, statistically evaluated for significance. This is eventually the baseline, this is the eventual population that entered the MRI arm of our study, 42 individuals. Average age was 54 plus minus 9 years, mainly men and mainly Caucasian men. I think we only had one African athlete, rest all Caucasians, with averages, the heights and weights here, body mass indices, mostly lean individuals, but there were a few outliers that have pushed up the percentage here. The overwhelming majority were runners. We had 7 cyclists, 70% of our athletic cohort was cyclists, mainly mountain bikers. We had several triathletes. And then you'll see the significance of this later on. So we had 9 participants or recurrent participants in the Cape Epic, and most of our runners took part, have taken part and still take part in the Comrades ultramarathon. The majority were recreational and some quite competitive recreational athletes, and a few professional or ex-professional athletes and Olympians. Exercise hours per week, 10 plus minus 5. And years up to 28 plus minus 11 years of endurance exercise. we had only one smoker, 8 previous smokers. Three of our athletes were known with hypertension, but only one used antihypertensive agents. No diabetics. 2/3 consume alcohol on a regular basis, and a substantial number had a family history of coronary artery disease, but of course all were assessed in depth. And I think in our larger initial group, we diagnosed 2 with obstructive coronary artery disease that were excluded from our study. So we ended up with only 40 athletes. 10 of our athletes were taking medication, statins, low-dose aspirin, bronchodilators, and then blood pressure. 3 of our athletes used antihypertensive agents. These are the findings of our contrast-enhanced MRI studies. We found very little left atrial scarring, 2.5%. On the median value was 2.5%, ranging from 1.1 to 7.6%. The fibrosis was unevenly spread over the wall of the left atrium. We found that those who had been taking part in the epic mountain bike races, so we were quite intense mountain bikers, had significantly more left atrial fibrosis compared to our runners. 7.3% median compared to 2%. But there was no association whatsoever between the fibrotic burden and the volume of the left atrium or the functional characteristics of the left atrium. So the amount of left atrial scarring was so little that it did not impair function in the least. When we looked at the left atrial and the left ventricular volumes, 3 participants were excluded because of poor image quality. The left ventricular end diastolic volume on average was 175 milliliters, which is slightly larger than that found in the non-athletic population, with perfectly normal ejection fractions and slightly larger left atria. I'll show you the comparison between non-athletic cohort and athlete and endurance athlete just now. Left atrial pump function was perfectly normal. Strain parameters were normal. And it was normal for as well as the reservoir, the conduit, and the contractile strain. There was no relationship between atrial strain measurements and left atrial fibrotic burden. And there was no association found between exercise hours, exercise intensity, and left atrial function, volume, pump function, and the years of exercise. These were the measurements, the functional measurements of the left ventricle and left atria, perfectly normal, slightly larger than that compared to a non-athletic cohort, as one would expect. Perfectly normal left atrial functional parameters, but with slightly larger left atria compared to the non-athletic population. We didn't have our own control group, but we did have a control group in Amsterdam that we used to basically compare our measurements with. So when we compare our endurance athletes to a cohort with atrial fibrillation studied in Amsterdam and a group of healthy control studies in Amsterdam, we see that the left atria and the left ventricle in our athletic population is larger as expected compared to patients with who are non-athletic or even those with atrial fibrillation or paroxysmal atrial fibrillation, and that the atria of our athletic cohort are smaller than those with paroxysmal atrial fibrillation. Now, the distribution of fibrosis in the left atria showed a non-uniform distribution with, so the left atria was carved up in 15 segments based on a study that was published in Spain. And we found that segments 3, 5, and 15 showed more enhancement compared to all the other 12 other left atrial segments. And 3, 5, and 15 are basically infraposterolateral around the left lower pulmonary vein. And the interesting finding is that the group in Spain reported the same changes, although these patients were suffering from paroxysmal atrial fibrillation. They also had substantially significantly more enhancement of the left infraposterolateral atrium, left atrium. So this is the cartoon demonstrating the left atrium and the regions that we carved the left atrium into, with segments 1, 3, and 15 around that left lower pulmonary vein here with far more enhancement, fibrosis. When we looked at the correlations between left atrial fibrosis, left atrial function, and volume, there was no significance, that we could not demonstrate any significance. All the p-values were high, and it was unexpected. The left atrial fibrotic burden was not different between male and female participants. There was also no relationship between the presence of left atrial fibrosis and age or body mass index. There was no relationship between fibrosis in the left atrium and exercise hours, exercise years, and also was no difference between runners and triathletes. We did, however, find that the intense long-distance mountain bikers, although we only had 7 of them, had substantially more left atrial scarring. And this is probably a hypothesis generating. We'd like to take this further within a larger cohort of athletes and focus on the mountain bikers and see if this is something that we could demonstrate, because this has never been reported before. Our data are quite novel, quite unique. And of course, the Western Cape is the heaven for mountain bikers. So we would have potentially plenty athletes. This is again to just demonstrate the absence of any significance between body shape, volume, type of sex, exercise, type of exercise, and not just hours, but intensity as well. We also looked at pace, training pace, and time in which these athletes finished their marathons and ultra marathons, and we found no difference whatsoever. We found no difference between the levels of participation in sports, so there was no difference between the recreational athletes and the ex-professional or Olympic athletes, and no relationship between exercise, left atrial or left ventricular functional characteristics. This is what we did pick up, and this is novel and very, very interesting, is the difference in left atrial fibrosis between the runners, the comrades, so the ultra runners, and the mountain bikers. We had Comrades Marathon participants who run Comrades 43 times without basically any left atrial scar whatsoever. And we found mountain bikers who'd done several epics and with quite significant left atrial scarring, 7 to 10%. So there's something to it, possibly. Now, so this study illustrates the low presence of left atrial fibrosis in lifelong endurance athletes with an uneven distribution along the left atrial wall, notably a presence of left atrial scarring on the infraposterolateral left atrium around the left lower pulmonary vein. And it seems that those engaged in long-distance mountain bike races may have more atrial scarring and may then theoretically also be at higher risk, future risk of developing supraventricular arrhythmias, atrial fibrillation, atrial fibrosis. But it just needs to be further studied. And there is a need for further studies. We'd like to follow our athletes up for another number of years and see if any of them develop atrial fibrillation. We'd like to study them with ultrasound and electrocardiography at regular intervals. And of course, eventually we'd like to expand our study to a larger cohort and include more cyclists and other disciplines and maybe resistance sports as well. Since we are a unique country with a mix of many tribes and nations, we'd like to include far more South Africans of different ethnic backgrounds and see whether there's any genetic differences in the response to long-term intense endurance exercise. We're very grateful for the support that we received from Siemens Healthcare, and it's mainly lobbied by Neil Lipschitz. And we're very grateful for Llewellyn and Cheryl, who helped us and blessed us with the contrast agent that we used in our athletes. Suresh Gorbin is the expert radiographer who flew in from Europe to teach us how to scan left atria, because it's a protocol that's very different from our usual scan protocol. We're very grateful for the support of VJ and the staff at Cape Radiology, who were willing to come in after hours and scan our patients, and kept it up till the last of our 40 had their MRI study done. And of course, most of all, we're very grateful to our athletes who often go the extra mile and drive from across town to come and see us and be assessed and followed up. They're really champions, all of them. And of course, I thank you for taking time to listen to me.
Thank you, JP. And it's great to finally see this data being presented. And this, as you said before we started, there's literally 5 times the volume of data that you presented today, which we really look forward to getting stuck into, but already some interesting findings. And I'm gonna ask if anybody has any questions. I've certainly got a question, and being one of the co-researchers, we haven't had a chance to fully interrogate this, but why do you think that we've got such lower rates of atrial fibrosis compared to, for instance, David Peretz's study, where he found, what was it, I think 14% in those high intensity endurance athletes? Do you think it's the intensity? And is that also maybe why the mountain bikers are more predisposed?
Yeah, but there's also been criticism of about the way they basically scan the left atria of their patients and athletes. So the protocol and their post-processing is quite different. In Amsterdam, they would use the difference in signal intensity of the blood pool against the left atrial wall, and the cutoff is 1.2 increase of signal intensity in the enhanced left atrial wall, while Perez uses what they determine to be, or what they think is unenhanced left atrial, normal left atrial tissue, and compare left atrial tissue to left atrial tissue. So there's major differences in the post-processing and the quantification. The method they use is very different from what is used in Amsterdam, and what's not just used in Amsterdam, but is used by other European groups as well. So I think Utah, Perez, and Marouche use their method is quite different and probably less robust, less reproducible. And it's remarkable that they find up to 10%, 9%, 10% of left atrial scarring in non-athletic healthy individuals. It makes you think. So the guys in Amsterdam aren't very impressed, and they're not the only ones with the methods used in Utah. So it may all be technical, basically. It would be nice if you would get access to their data and analyze their studies the way they're analyzed in Amsterdam, and see if the differences really stand.
Well, that's reassuring, at least, that there are lower rates according to our methods. Does anybody else have a question for JP? Steve, go ahead.
Yeah, thanks for a very interesting presentation, JP. What role do you think dehydration might play in left atrial scarring? Because the assumption seemed to be that it was the strain on the heart muscle that created the fibrosis, but there could be a number of explanations for scarring that are not necessarily related directly to the load.
Yeah. So other explanation, and that's late gadolinium enhancement. It doesn't just signify scarring or fibrosis. It can, but it could also signify inflammation or acute necrosis. So gadolinium contrast agent gets stuck in leaky myocardial atrial cells as well. And of course, it gets stuck, or it's washed out more slowly in an expanded interstitium. So it's not always scarring, although we think in these patients it more than likely signifies scarring. But we must consider other etiologies as well. Now, so your question about left atrial scarring and strain, would there be other explanations?
Or dehydration, specifically in the long distance bikers, because they're out there for so long in South African conditions.
Yeah, I'm not sure if I've ever read any paper about dehydration causing left atrial scarring or fibrosis, or stimulating the cellular pathways that would enhance scarring. I can imagine that dehydration, as we all know, causes direct changes in volume of the heart and volumes in the atria, and can then result in atrial fibrillation, atrial flutters, atrial arrhythmias. But I've not seen I don't think I've ever seen a paper demonstrating if it's preclinical or clinical relationship between dehydration and scarring. But definitely changes in volume. We assessed runners. Jeroen knows we looked at the hearts of full two ocean ultramarathon runners before and after. We actually scanned them the day before in the exhibition, and as they ran, sometimes walked over the finish line, we assessed them again in a tent. And we found changes using the same technologists, the same machine, same post-processing technology. We found changes in atrial volumes and ventricular volumes as well, and no change in strain, in atrial strain, but these were the acute changes. Yeah. Have you come across any papers that suggest that chronic or recurrent dehydration may result in fibrosis?
No, I'm just hypothesizing what the causes might be, other causes. And why the mountain bike is the epic mountain bike is exceptional.
I think we know, but this is now talking, I'm a cardiologist, so we think of coronaries as well, although I'm often more interested in other cardiac structures. But we know that, the papers that came out recently, European papers, Belgian, Dutch, and I think there's even one from London as well. They looked at coronary artery disease in athletes, and they found that the intensity, the pace that these athletes kept up during their races correlated with the presence of coronary plaque and soft plaque as well, not just calcified plaque. So I know that the mountain bikers, we've been there at EPIC, we've assessed a few EPIC athletes as well before and after the race with ultrasound, looking at the acute changes. But they push themselves with high heart rates, very intense, not like running a Comrades, where many of our athletes were recreational athletes. So they run to like Comrades in 9 hours, 10 hours, 11 hours, they just make it. And just a handful of them were far faster than that. But so it's relatively low intensity, but long duration. But mountain biking, like Cape Epic, is intense, high heart rates. Then it's a different position, basically sitting bent or standing over your handlebars. Then there's the mechanical interaction as well. There's the vibrations. I'm not sure if that could play a role. It could potentially. And the one question you haven't asked is, why would the scarring predominantly affect the left lower atrium around the left lower pulmonary vein? Now, the idea is, and this is a paper that came from, has just been published actually by Marco Gutter's group in Amsterdam, in I think European Journal of Cardiovascular Imaging, is that the idea is that, and they've demonstrated this, that the descending aorta runs directly behind the left atrium and touches the left atrium, and they demonstrated a smaller distance between that left atrium, exactly there where the left pulmonary vein comes out, or comes in actually, and the descending aorta. So there's mechanical stress and strain, there's direct impact of that aorta on the left atrium. And their idea is, that's what they came up with in Amsterdam, and I think I kind of support it, because they demonstrated this in other non-athletic individuals with atrial fibrillation, with unfolded aortas, is that mountain bikers who sit and stand on a bike for hours on end, pushing themselves to the limit with high heart rates, there's far more pulsatile interaction, I say, direct connection, direct impact of the pulsating descending aorta and the left atrium around that left lower atrial segment.
Interesting. Thanks.
Vijay's got a question, but before he asks his question, Vijay, I just want to also say thank you for your team and the work that you guys did in terms of getting the cardiac MRIs done. We wouldn't have been able to do it without you. So thanks to Cape Radiology and you, and of course all of your team there that assisted in this study. And we appreciate that.
Thanks, Jeroen, for those words, and JP for introducing us to this. And it's wonderful to see where our work has actually ended up, and the amount of data that you've managed to get out, how much of information you managed to glean from what we've scanned. Just a quick question about it's also with regards to the cyclists versus the runners, and if the postulation is that the cyclists work their hearts a lot more than do the runners, the extremes of heart rate, etc., for sustained periods. Is there any correlation in our study here in terms of LV mass? Do the cyclists have more LV mass, more athlete's heart? Is there EDV or a strain correlation difference between the cyclists and the runners? I might have missed that somewhere, and I apologize if I did.
No, not really. So not really. But of course, we only had like 9 cyclists, so we need to expand. And I haven't. So I've just presented the MRI data. We've got far more data and ultrasound data as well, looking at both atria. And the right atrial data, they're still working on in Amsterdam because it's so much more work, basically. But not really. So mass-wise, volume-wise, strain-wise, there's no difference between the different disciplines. The only difference was the presence substantially, significantly more of left atrial fibrosis in that particular segment or segments. But then we only we compared like 9 to, what is it, 9 cyclists to 26 runners.
Yeah. So yeah, even though the numbers are not allowing us to make concrete conclusions, and it lends credence to what you're saying. It might be an anatomical thing, the position of the aorta to that part of the left atrium and the way the cyclists are keeled over, whereas the runners are standing erect. So that's extremely interesting and definitely behoves further investigation. So well done, JP. That's wonderful to hear the data, and that's all I have for now.
Thanks, Vijay. Does anybody else have a question? Okay, if not, JP, thank you very much for putting the data together for us so soon after finishing the study, and I look forward to analyzing it all with you in the weeks to come. And thanks for presenting it today. And thank you to all of those who attended. I hoped for a bigger turnout. I don't know what happened to all of our colleagues, because we normally have quite a few more people, but nevertheless, it was great, JP. Thank you so much.
Thanks for the invite. Go well.
Thank you very much.
Thanks, everybody. Wishing you all a good day further, and stay well.
Bye.